Uh, Good afternoon, everyone. Thank you for coming over, and despite the heavy rains and the floods, we are all here to listen to the speakers today. We are very fortunate that we have very good and very intelligent doctors who will present uh, their findings. No, and we are very glad that they accepted our invitation to be a speaker in TPUP. Alam niyo ho, no, marami talaga tayo mga kababayan na may mga sugat, no? And malaking bagay ho pagka tama ang management na ginagawa for the patient. And yung mga malalaman niyo today, maaaring hindi niyo pa naririnig ever, no? Kaya it's really a blessing for us that we are here and we are discussing this. And so ang aming TVUP ho ay talagang sa ano ho ay pangmatagalan na na ah, na pangmatagalan na matututunan ho nyo, no? So let us all sit back and relax, and we will start our presentation. Sandali lang po at inaayos ko ang
Go ahead, ma'am. Okay lang po. Go ahead.
yan.
Good morning, everyone.
Ayos lang. Okay, si Raymond po.
Okay, sorry. Time check, but time for me is 11:59. So I'm trying to figure out if I got into a wormhole kung ano mali ang aking time. But okay, good morning, good afternoon, good evening po sa lahat. And very welcome po on this rainy, medyo maulan po, no? Sana po kayo po ay all safe and secure in your homes at kayo po ay keeping warm. Marami rin pong may sakit sa araw na ito. For today, we will be having our 257th episode po for Health Updates webinar series brought to you by the University of Philippines. So thank you po for being part of our credible online community, and for all those who just discovered us today, welcome po at saan po marami po kayong matutunan. At pag-uusapan po natin ngayon, very simple, very common, pero hindi po natin masyadong siguro napagtutuunan kung paano po ba yung mga tamang pamamaraan. So right now, we have unprecedented challenges and also medical advancements patungkol po sa landscape ng tinatawag po nating wound management po, no? So today, we'll be talking about start off po, no, a review of paano po ba ginagawa yung mga wound assessment methodologies, highlighting the critical role of accurate differential diagnosis and risk stratification. Will also, ano po ba yung mga various phases of wound healing and the factors that impede them by providing scientific framework, kumbaga, for developing individualized treatment protocols. Ano po yung mga tinatawag na debridement, no, diba? The conservative and surgical debridement techniques, ano po yung tinatawag na mga maybe state-of-the-art dressings na bago po, no? And maybe other adjunctive therapies. Pag-usapan po natin lahat-lahat yan, maybe from mga kakasugat po, no? From acute traumatic injuries, others like recalcitrant chronic ulcers po, no? Yung diabetic foot syndrome. So for today, we are very thankful, very happy po that you're still able to join us in this rainy Friday po. No? This is the Health Updates program, and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during our regular Friday, and also my pleasure and honor to host this program together with Dr. Stella Marie Jose.
Good afternoon, Dr. Raymond, and hello to all our participants here in the live broadcast of the Zoom webinar, and to all those watching via live streaming on TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and of course, all those watching in TVUP Signal Channel 101. For today, we have two main speakers, both of which are consultants of the Department of Dermatology at the UP Philippine General Hospital. We have Dr. Nicole Marela Tan and Dr. Val Constantine Cua. They will underscore the significance of a holistic, patient-centered approach to care by recognizing that optimal outcomes are achieved through multidisciplinary lens. They will help bridge the gap between the theoretical knowledge and the practical application by providing actionable strategies for integrating this advancement into daily practice, whether in a hospital setting or in a community-based care. So in this episode, we will discuss how we can contribute to enhancing health outcomes and mitigating the considerable morbidity associated with poorly managed wounds across the Philippines. But before we go to our presentation, Raymond will introduce our person on the street video.
Sorry. So for our person on the street video, it helps to set our discussion into context. So we come up with very, very short video lang po, no? Several interviewees. And thank you for the hardworking team behind this, our webinar production team po, no? Questions that we pose to our interviewees are as follows. Ano po ang ginagawa ninyo kapag kayo ay nagkakaroon ng sugat? Paano po ninyo nililinis ang inyong sugat? Mayroon po ba kayong pangbalot sa inyong mga sugat at ano po ito? Sinong doktor po sa tingin ninyo ang nag-aasikaso at sino po yung mga espesyalista sa mga sugat at sa tingin po ninyo kailan dapat magpakonsulta sa doktor kung kayo ay may sugat? Please watch this.
Usually, as a dancer, parang very prominent naman na magka-injury, magkaroon ng sugat because in the dance industry, in the sport industry, it's a very physical, heavy tasking, heavy kind of activities.
Pag nagkakaroon ako ng sugat, I usually just always wash it with water kagad. And then, of course, I use clean soap, okay, not just any other regular soap or what.
When I have a wound, I usually clean it as the way we are taught at school.
So, pag nagkakasugat ako, I usually just try to clean it off with water. And if I have bandage like Band-Aid or like something cloth that on takip, I use it.
Safely na lang, I use, what do you call this? The soap with the guard. Yeah, so I just make sure to really clean the wound and then wash it. And yeah.
Most of the time, since I'm in a dance studio, the most available thing to use is water. Kasi, but if there's like alcohol or betadine, that also works. I also use that.
Just alcohol, just regular alcohol. Depending on how deep the wound is, but usually I don't get that deep of a wound, so.
If it's not unavailable, well, if there's betadine on hand, I immediately apply betadine on it and just water.
Usually I use Band-Aid or gauze if I have gauze and gauze tape. If the bleeding is severe, I use clean cloth.
Oh, after cleaning it up, I just use depends on the size of the wound. If it's really that small, I just use a Band-Aid, just a regular one. If it's a little big, if the gauze is available, then I would gauze it and tape it.
As soon as I get it, I just Band-Aid it, but then I take the Band-Aid off and I just let it breathe because it heals faster once it's definitely use gauze for larger wounds to prevent infection, especially if it's really deep.
Honestly, if I'm being honest, I'm not really into not really knowledgeable about like what type of doctor, but I mean, if there's a nearby clinic and just it's a first aid, I mean, it's just that, yeah.
I don't feel you need to visit a doctor, but just general doctors, I guess, or nurses would also be good for wounds. It really depends on how bad the wound is.
If may mga sugat ako, the first thing that comes to mind is because nag-training ako before with Red Cross, so usually like yung first aid respondents yung una ko naisip when it comes to treating wounds.
All right, thank you so much to our webinar team and thank you also to our interviewees. Even if medyo ulanan po this week, we were able to get them in a very short amount of time po. No? Just a little bit of housekeeping for today. All those who are asking certification of attendance, you all know that you'll be given if you have watched at least 50% of the webinar duration. If you have any questions, feel free to email us at our up.edu.ph email account. For today, we'll be having a panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. We'll get our webinar underway. Dr. Stella will introduce our first main speaker for today.
Our first speaker is Dr. Nicole Marela Tan, who is a consultant at the Department of Dermatology at the University of the Philippines, Philippine General Hospital. And so let's hear the talk of Dr. Nicole.
Hi, good afternoon po. Teka. Okay. Can everyone see my screen po?
Yes, go ahead.
Oh, okay, sige, let's get to it. So good morning, everyone. Before I formally begin, I'd like to start off by showing this case. So let's say a clinician calls you up to say they're referring this wound patient to you. Clinician 1 just says leg ulcer looks infected, while clinician 2, who was actually able to attend this webinar, tells you the ulcer measures 4 by 2 by 1.5 with the exact location, with the slough, and with the peri-wound erythema. Which of these would you rather receive as a referral? So I think we can all agree that clinician 2 gives you much more information and helps you prepare to receive the patient the next day, so you know what you are going to do. Now, the problems are wound assessment is often very inconsistent and subjective, and this poor documentation and monitoring leads to miscommunication between providers, delayed or inappropriate treatment, and difficulty tracking healing over time. Now, so today we're going to tackle that a little bit. I'll be discussing the first half on wound assessment, and Dr. Guo will be discussing approach to treatment using dressings. Again, I'm Dr. Nicole Marelatan from the PGH Department of Dermatology. This is just going to be our short outline. Now, this is a very structured checklist that we call the 9 C's of wound assessment. It helps us describe not just the wound, but also to understand the causes, the context, and the care that each wound requires. For this one, we'll just be focusing on the first 4 for the initial assessment. Now, when you see the wound, you have to first, of course, take note of the appearance and the characteristic. Get a very clear picture of what the wound looks like, because this will be the basis for your local wound management. And then, of course, you have to take a note of the etiology of the wound and the whole patient background, the cause, the comprehensive picture of the patient, and any contributing factors, because this will dictate your management from an overall medical perspective. You have to see the whole but treat the whole patient, because different types of wounds require different considerations. So from left to right, you would do something different when it's an infection, an arterial problem, a venous problem, or something that comes from immobility or pressure. And the wound terminology can sometimes be a little intimidating, but it's easier when you break it down to the individual parts, and that's what we're going to do today, using the TIMES framework. So TIMES stands for tissue type, I is infection, inflammation, M is moisture balance, E is the edge of the wound, and S stands for surrounding skin sensation and systemic factors. So we'll go through this one by one, starting with tissue type. The first thing you have to do when you're assessing your wound is assess whether it's viable or non-viable tissue. Buhay pa ba yan or kailangan na ba siyang tanggalin? So this is what healthy granulating tissue looks like. It's bright pink, medyo red, medyo bumpy, mukha siyang ground beef. And this is a sign that you have good formation of new blood vessels and collagen, and it's supplying oxygen and nutrients to your wound that will help it heal. This is what you want to see. Sometimes we're very familiar also with the crust. This forms after yung liquid magtitigas sa ibabaw. So it can be serosanguinous crust, hemorrhagic crust, sometimes it's pus, but it's better to actually remove all of that through compresses. Gentle compresses, something even the patient can do at home, and slowly do gentle debridement. What's more alarming or dangerous is if you see this. Now, the bottom two, these are 2 kinds of necrotic tissue, your slough and your eschar. Your slough can be soft or adherent. Usually, it's like rubbery or stringy, yellow, green, or white. And your eschar is your brown to black, dry, thick, leathery tissue. And both of these indicate that you have a much deeper injury going on. When you have these on top of your wound is automatically unstageable. You actually don't know how deep it goes. Pwede yan umabot hanggang fat, muscle, or bone. So you have to remove it to do a proper assessment to guide your management. You also need to watch out for any vital structures. So we have patients who have very big and deep ulcers. And you can see that from the 12 o'clock to the 3 o'clock, you see that yellowy, rubbery slough. But if you continue your eyes looking downwards, you have this fibrous, ropey tissue. Those are actually already your tendons. So when you're doing your debridement, you don't want to remove this part, because these are, of course, essential structures. You also need to watch out for any foreign bodies. So very common for patients na natapilok, nadapa, lupa, semento. You need to remove these little bits, otherwise they will form foreign body granulomas, which can be uncomfortable for the patient. For infection and inflammation, very important to differentiate between contamination, colonization, and a real infection. So because you have a break in the skin barrier, almost all wounds talaga, they will have contamination or colonization. Differentiate from a real infection, you're watching out for fever, increasing pain, erythema or pamumula, warmth, swelling, or fluctuance. And when you take your culture samples, what's suggestive of a real infection is if you have more than 10 colonies per millimeters cube. Another thing you have to watch out for is biofilm formation. For example, you have a patient who has gone several rounds of antibiotics, has had the infection for more than 30 days. The new tissue that's growing is very friable or mabilis siya mawakwak, mabakbak, nagdudugo. Or you have this jelly-like film material on top. Those are all signs of biofilm formation. And this is microbial cells that actually prevent your wound from healing. You have to remove this through debridement and proper dressings. Otherwise, hindi siya magsasara. It also forms this layer on top of the wound na whatever antibiotic you put on top or whatever dressing you put on top, it's not able to penetrate well. That's why you have to get rid of it. M is moisture balance. So your wound exudates are actually a very essential component of wound healing. And your wound needs to be moist to heal. So hindi totoo yung pabuka mo siya, patuyuin, and it'll heal faster. You do need a certain amount of exudate because that's what helps the wound close up. The skin cells move towards it. And if it's too dry, this is what it looks like. It causes actually delayed epithelialization. If it's too wet naman, it's more prone to maceration and infection. So para siyang Goldilocks. Hindi pwedeng sobra, hindi pwedeng kulang. It needs to be just right. And it's your dressing choice that also helps dictate and reach this optimal moisture. E is the edge of the wound. So when you're looking at the edge, you're looking at the edge because this is what helps you determine whether it's healing well or not. And you want to achieve 20 to 40% reduction in your wound area after 2 to 4 weeks. If you're not getting that improvement, you need to reassess if your current treatment is effective or if there's something else you need to be doing. And for wounds, especially the chronic ones, we need to watch out for undermining or sinus tracts and your epibole. Your undermining looks like this. So on your wound edge, you can see yung cotton pledget. It goes through about maybe 2 to 3 centimeters deeper. So parang meron siyang pocket. Kung ito yung ibabaw ng sugat, meron pa siyang bulsa dito. So the wound is actually much bigger than what you think it is. There's also something called tunneling. Para siyang rabbit tunnel palalim. Okay? The wound, for undermining, it's directly attached to the wound edge on top, but tunneling can be anywhere on the bottom of the wound bed. Para siyang rabbit, kuneho na nagbaburrow. Your epibole is another thing you have to watch out for. So if you look at the wound edges here, they actually look clean and closed and healthy, but that's a bad sign if you have a gap that's still this big, because it's a sign that your wound edges have curled up and healed this way. So it's a sign that actually stopped the wound healing and it will not close this way. So you actually have to destroy those edges so that you restart the wound healing process so it can close over again. Now, S is your surrounding skin, the sensation, and any systemic factors. You need to watch out for any surrounding erythema, induration, or maceration, or dermatitis that can actually come from inappropriate dressings or dressings that weren't changed appropriately. You also watch out for sensation. So a lot of these wounds are very painful for our patients, but you also need to watch out for loss of pain because if they're not feeling anything, that means tuloy-tuloy na nangyayari yung trauma or tuloy-tuloy na nadadaganan or ang laki na pala hindi lang nila alam. They're not able to detect it. So you need to be extra careful for these patients that actually don't feel any pain. And of course, you have to consider, again, the systemic factors, the glucose control, the vascular status of these patients, all of which contribute to your overall wound healing. Okay, next for clinical workup, we're looking at the causes of the wound, the comprehensive picture of the patient, and the contributing factors. Now, this is a truly, wound assessment is truly very comprehensive. It goes past your usual past medical, family medical. What I would like to point out are the nutritional status is very important for your patients. They need appropriate They need a good amount of zinc and protein to be able to heal properly. And also very frequently forgotten are actually your psychosocial and your logistical problems that your patient will also have to face. Because wound care is a very long-term effort and truly multidisciplinary that the whole team, both medical and family, will have to find ways to make it sustainable. And when it comes to workup, we have to remember that we don't order every possible test for the wound. Of course, you want to be cost efficient, and our approach should always be guided by the clinical context of the patient. So if you're looking for blood work, for infection or glycemic control, of course, you order the appropriate labs. Albumin is a good marker of nutritional status or protein wasting. You do imaging if you're for very deep wounds, and of course, your vascular tools to check your arteries and veins to check for proficiency. For microbiology and histopathology, these are very important, of course, if you want to be guided by, if for antibiotic guidance, and if you need to rule out any atypical or refractory wounds, or if you're considering malignancy, then you'd have to take a biopsy. I will point out that when you're taking your tissue culture, you need to do it, or tissue culture or tissue swab, you need to do curettage or debridement first. Kailangan mong tanggalin yung top portion. Otherwise, you're just getting contaminants and colonizers. You're not getting what's actually causing the infection. And if your wound is not improving after 4 weeks of good care, remember that you can and should refer to our other friends in the medical specialties that can help you with certain things. Finally, documentation. So for this last part, these are patient photos. I will ask you to kindly refrain from taking screenshots. I promise I will list all the tips at the end as a summary para hindi kayo mahirapan. Number 1, so describe objectively. When you're seeing your patient and all you put is day 1, ulcer inflamed with pus, day 10 improved, it doesn't give you a good idea of what's happening. And then what will you put on day 17? Improved more? Syempre, you don't know. Like improved can be 10% improvement, can be 90% improvement, which is a big difference. So you should describe using the times framework that we just discussed. It takes practice, but it gets easier the more that you do it. And it also allows you to be very objective, specific, and measurable with your improvement. And anyone else who sees that chart also gets a better idea of how much this patient is improving or not improving. Next, I can ask the pinakamatalinong doctor in this room, and where is this wound? And they would have no idea. And if you look at your camera roll 1 week from now and many patients later, you would also have no idea, which is why it's very important to take your photos with landmarks. You already know that your wound is going to change with time, so include something in the photo that doesn't change. And in one glance, it also gives you a very good idea of how much improvement has gone in that time, diba? With one photo, because the nipple will not change and you know it's on the chest. Next, measure consistently. So it's good to include the ruler or the scale that you're going to use. It removes a lot of the doubts kung saang length and width ba to tinake. But also remember that your wound is 3D. So you're not just measuring like the 4 by 3 centimeter defect on the top. You actually, if you can see, I can put my finger all the way in. So 3 centimeters papasok siya. So you have a 3 centimeter undermining or tunnel at the 6 o'clock region. And it's good to, a nice little tip is to draw the border of even the undermined area as part of your documentation. So it helps you later on also to see when you're tracking this patient. Gives you a better idea of the whole defect, not just the one on the surface. Next, measure consistently. So when the patient comes to you, you're not gonna, on follow-ups, hindi mo na maalala, or was I on the right side? Was I on the left side? Was I at your foot when I took this? And then when you're comparing your length with depth, parang why are the dimensions so different? So try to standardize it as much as possible. When you measure the length, take it from the head to the toe of the patient, and when you're taking the width from side to side, and make sure that these measurements are perpendicular to each other. For the depth, of course, you take the deepest point. You're also looking for any tunneling or sinus tracts. You use the clock method. Make the head the 12 o'clock, the foot 6 o'clock, and 3 o'clock, 9 o'clock, of course, are your right and left side. So you can say for this photo, you have tunneling at 7 o'clock with a depth of about 2 cm. So when you do these measurements over time and always the same way, they become more reliable and comparable. Next, again, the wound is 3D. So when you're looking at this patient from the top, at this wound from the top, you can't actually see how elevated it is until you see it from the side. So also remember to take your photos in different angles. Again, with your landmarks, you're able to take very consistent photos, and you can see the improvement over time. Very reproducible. Same with the side. And I chose to show, okay, I show this patient because this is typically what we would see more every day in our clinics. Again, looking from the top, you don't see how swollen it is. From the side, you can see there's very significant erythema and swelling. And this patient already has cellulitis with, he had fever, 39, 40 degrees over the last week. So I gave him oral antibiotics, and by the time he followed up on the third photo, you see the yellowish slough. So we did physical debridement at the clinic, and you can see that it's deeper, but you wouldn't think that it was that deep looking at it. But removing it, you get the better assessment of the wound. And then track it over time. Try to do standard photos as much as possible, and it helps you see how well this patient heals. It's also nice sometimes. I do take photos of what dressing I use, so I remember also. There. So as the in summary, when you're taking your photos, documentation monitoring, of course, make sure you have informed consent. Describe objectively. Don't be vague. Use the wound terminology, the times framework that we just learned about. Measure consistently, length with depth. To use the tunneling o'clock method. Photograph smartly. Remember, your wound is 3D. Standardize as much as you can. Include a ruler, a scale, and use your landmarks. Monitor with a framework times, or there are some other special wounds like they use the push tool for ulcers, and update over time. So comparing your standardized photos helps you track your progress objectively. So very careful and systematic assessment and documentation really enhances communication and guides our management. And in the end, better care starts at the beginning with the way that you look at that. Thank you very much. I'm Dr. Nicole Tan.
Thank you very much, Nicole, for your presentation. It's really an eye-opener for me kasi I'm an OB, so hindi ako masyadong nakakita ng ganyan. Pero we learned a lot from your lecture, and I hope the others, our audience, take note of yung kanyang mga sinabing data. I think, Nicole, there are questions in the chat box. If you could answer them na lang, so we can move forward. Our next speaker is Dr. Val Constantine Kua, who is also a consultant at the Department of Dermatology at the UP-PGH. Okay, up to you now, Val.
All right, let me just share my screen. Okay. All right, can everybody see the screen?
Yes, it's very clear.
All right, so good afternoon, everyone. My name is Dr. Val Kua. I'm part of the Division of Complex Wound Care of the UP-PGH Department of Dermatology together with Dr. Tan. So my topic today will be about debridement and dressing. So the practical tips on how we actually clean the wound and how we wrap it. And I have nothing to disclose for this lecture. We always begin with the wound bed preparation paradigm. As Dr. Tan discussed, when we treat the wound, we do not treat just the hole, but the whole person itself. So before you even tackle about debridement, you always have to think about what caused the wound and what are the patient-related factors, comorbidities, financial capacity of this patient for us to be able to treat the wound. Because if the patient lives far and cannot come back for follow-up, then we won't be able to monitor the wound properly. And she also highlighted the importance of nutrition. You also have to prognosticate the ability to heal, because we have to be able to tell the patient and expect when this wound would close. And most of the time, it's not just 1 or 2 weeks before we go to the local wound care. When we do debridement, the reason why we repeat it is because we want to restart the wound healing cascade. Whenever we touch the wound, let it bleed, we go back to this hemostasis and inflammatory phase. And this is what we want. We convert the wound from a chronic one to an acute one so that the body can recruit healthy cells to fill up that gap in that whole wound and eventually close the wound. And that's the purpose why we have to do debridement. And it's not just a one-time thing. Dr. Tan was able to discuss as well the different terminologies that we have to do with wound, but I like to tackle more about the biofilms because biofilms are not uniformly present in the wound. This is just an example of a pre and post debridement. You can see the one that Dr. Tan told us before was the granulating beefy wound bed that we want. And 80% of the infection is mostly due to the biofilm, and it can trigger a chronic inflammatory phase. We want to be out of that inflammatory phase, and that's why we do debridement and proper dressing. And remember that biofilms are not uniformly present. But in the advent of new technologies, we do have this wood slam. The one we use in dermatology to identify yeast infection or bacterial infection has also been useful in the realm of wound care. When you see a red fluorescence on the wound, it actually highlights an area with extreme bacterial contamination, and that is an area where you want to also target your debridement and remove that red fluorescence to actually reduce the bacterial load. And this will show us what it looks like without and with the wood slab. And this is just a nice paper that tackles what we actually see under the UV light. So if it's red, you actually get it from the porphyrin producing bacteria. Well, it's green, it's from the extracellular matrix and it's healthy. In my practice, I had not seen any cyan color yet, but they say it's due to Pseudomonas. Now, with wound debridement, we go back to the time concept or dime concept, whichever paper you read. Basically, we want to take out those devitalized tissue, address the infection and inflammation so that we can get out of the inflammatory phase and balance the moisture and make sure that as the wound bed granulate, the wound edge also tries to crawl on the wound. When we remove tissue, it's not just removing anything we want. We have to know what we have to take out, and we also have to assure that there's adequate vascularity. And the point of, I guess, the advantage of being a dermatologist is that we are quite obsessive with measuring and documenting the sizes. And I think this is a basic practice that even general practitioners should have in their uh, armamentarium when looking at wounds. Now, I'll not be discussing all the debridement types, but basically the two things that we always have in our practice. One is autolytic debridement. Autolytic debridement means auto, self. It actually uses the wound fluid of your wound to lyse, to soften, or to get rid of that gunk, those necrotic tissues out. And we use this together with our advanced wound care appliances. This is actually helpful for those patients who are not a candidate for surgery. But if you want to be very quick about removing those dead tissue, of course, surgical sharp debridement is more directed, and you can control what you take out. And there are a lot of types. So let me show you some examples from this video. So in here, we use a curette, basically a stainless steel round cylinder, just we use to scratch to remove the slough. Or we can actually use the side of an iris to gently take out the crust. And as Dr. Tan mentioned a while ago, we do not like the crust on the wound. It's not actually a good thing. It's actually hindering the wound from healing. It's a basic misconception that we all grew up to believe that having a crust is good. And you can also use your iris scissor to take out bullays or blisters. You don't want to really be uh, aggressive about. You want to gently take it out so that you can identify the structures that are being exposed. And when you have an example of this extravasation injury, commonly we see this in the inpatient undergoing chemotherapy or those in ICU. You get this very bad injury and you can gently remove it bedside. You don't even have to bring them in the OR, so long as you know how to approach this one. And just like to see, these are my residents in PGH doing this bedside debridement on a patient with an extravasation injury. Remember, we want those necrotic tissues out so that we can use our advanced wound care appliances to help the wound heal. Otherwise, this will not close and you will be left with a stagnant chronic wound. Now, if you have this available in your clinic, we have this ultrasonic wound debridement wherein it's like oral prophylaxis for the wound, wherein jets of bubbles are blasting on the wound, taking out those slough, but gentle enough not to cause so much injury. And as you can see, the pre and post debridement really looks well compared to just scratching it with your curette. And it's like I also it's emphasized knowing what to take out because remember, not all yellow is slough. Yeah, slough can come in as green, brown, depending on what the bacteria wants to show us. But tendons can come out as yellow, and you have to be careful not to take them out. Okay. Now, when we take out through our debridement, especially with this kind of with the Peabody, you have to remember that you do not have to stop only at A and B because at B you still have crusts behind it. You have to extend to letter C to be able to recruit more healthy cells to replenish what is missing in that wound. So a lot of times it's a misconception that, oh, doctor, you're making the wound bigger. No, we have to make it the wound bigger so that I can get to the healthier part of the wound that will actually bring in more healthy cells to close the wound. And then before you get any samples for culture, please do not take the slough as a sample for culture, you'll just be getting polymicrobial contaminants that are not healthy. And as you can see in this picture, this beautiful red fluorescence here really tells us that this is a very dirty wound that you need to take out, do your debridement, and when you're doing your culture, do take 4 quadrants. Ideally, you send each of them to for culture, but in government institutions, we had to admit that we have um, problems with resources. So you can't put it all in one clean sterile vial and send it for culture. And hopefully that will give you the more accurate bacteria that's causing the problem in your wound. And you can see here after the debridement, there's no more red fluorescence on the wound slab. Now, what wound dressings do we use? We'll always have to understand the concept of moist wound healing. The wound has to be moist so that the cells will be able to climb, to swim, to close itself. Because when you have this cross on top, you can see that the cells are trying to dig under to close itself. So this actually emphasizes the importance of not having a cross on your wound. But of course, when the wound is already very small, you don't have to be very OC about it. You can just leave it as is. But if you want to be aesthetic about the result, then you really have to take out the crust. Why can't we use saline moistened gauze? In the olden times, yes, it actually can be used because this actually acts as an osmotic dressing. They will actually get the fluid and the blood from your wound, absorb it, but when it dries up, it will no longer absorb any and it will stick to the wound. And when you take it out, you are left with this erosion. And actually, this takes out some of the healthy cells that had already been deposited, and you will be having pain and delayed wound healing, and your patients will not love it. And there are also studies here that show that moist gauze is less effective in preventing bacteria from entering the wound. That's why I always encourage my residents now that even though it is a bit expensive compared to your probably your sterile gauze and micropore tape, it is better to use our wound dressings, especially if it's available in the hospital. And remember, this can be availed through PhilHealth if it's available in your in-house or outpatient pharmacy. Now, the decision to do the dressing first. Do we have an infection? Do we need to start on antimicrobial? If it's granulating or necrotic. If it's necrotic, how much do we take out? And then afterwards, is it wet or dry? So these are the things that we have to think about when we are dealing with the wound. And the ideal dressing, again, has to maintain that moist wound environment and provide autolytic debridement so that what you can take out from the surgical debridement can be taken out by your autolytic. Ideally, it's conformable. It shouldn't be too difficult for the patient to move. You don't want to restrict movement. And ideally, it comes in numerous size and shape. It provides thermal insulation, barrier for the bacteria, and pain-free for removal. So let's talk about the basic things that's available in the Philippines. You have your transparent film dressing. Again, I'm not promoting any brand here. These are just examples that we have here in the country. So this is actually literally a film that can be with or without a gauze. And I like to just keep it as a barrier. Think of it as next level band-aid. So with this acrylic sticking onto your skin, you actually do not have any avenue for your bacteria to enter, and you just keep the wound protected. And I like it when I'm doing your biopsy or a very small wound area, but it can also be used for a very large area that the patient, example for this burn patient that I don't have any dressings before that could cover it, I use this dressing. And sadly, it's not as effective as the other dressings. So I would shy away next time from using transparent film for bigger wounds. Maybe just for the biopsy and for just small cuts, that would be fine. And for transparent film dressing, they have acrylic. So the acrylic can be an irritant. The more you remove the tape, more skin gets taken out. Eventually, you will have an erosion. That's why you have your barrier film that you spray on the areas where your adhesives are so that it will protect the skin. And I don't know if it's visible on the screen here, but you can see the shiny area and not shiny area. These are the areas that I've sprayed with the barrier film so that the adhesive will stick to that and not on the skin itself. Now, I think this is the most common thing that we see in our drugstore, this hydrocolloid dressing. Duoderm, Coloplast, there are a lot of brands, but basically these are carboxymethyl cellulose dressings with a gel that absorbs the fluid and it keeps the fluid on the wound. So it actually provides autolytic debridement, but you have to be careful. You have to actually provide 1 inch of space from the wound itself to allow the accumulation of the fluid there. They say that you can leave it on for 3 to 7 days, but in practice, 1 day is more than enough because by that time, you might have excessive granulation and maceration, similar to what this patient had when she left it for more than a week. I like using the hydrocolloid dressing on very shallow wounds, such as your pressure injury stage 1 and 2. Stage 1, no break on the skin. Stage 2, you have a break on the dermis. Because why? It's easier for the patient to apply, doesn't need a nurse to help you with it, and it's not so bulky. But remember, it has some adhesive, so it can be a bit irritating for patients who become sensitive to the irritant acrylic adhesive. I also use it for this very small wound from a patient who actually went for a hair removal but got burned instead. So, but the problem is the patient came in a bit late in to my clinic. So I always tell that patient the earlier you seek consult, the better cosmetic outcomes that we can achieve. And this is the best that I can do. I mean, it's better than the weeping fluid, but there are already atrophic scars. But in dermatology, we can fix it with our lasers, and I think that's the next step for this patient. Hydrogel dressing, literally, these are like hydrophilic polymers that actually just wets the wound. It is meant to soften the eschar, take out the slough that can be taken out during your first debridement, and because it actually helps with your autolytic debridement. But you have to be careful about peri-wound maceration if you leave it for long periods of time, and you would need a secondary dressing. So this is what it looks like. So I love using it for this kind of eschar where it's quite difficult at first to take out. So give it like a week. So with hydrogels, you have to change it every other day. Otherwise, it will dry up immediately. And when you soften it enough, you can do your debridement and eventually take out that yellow stuff and shift to your primary dressing. As this is what it looks like, that vessel from the extravasation injury. We also have honey. Honey is quite helpful because it reduces edema. It lowers the wound pH. Remember, when you have bacterial infection, the pH goes high. That's why your lidocaine doesn't work. The lower pH actually helps the fibroblasts proliferate, but it can sting. However, it is very good with the highly colonized wound because it covers a lot of bacteria, but you have to change it daily. And this is what it really looks like from the perspective of when you're using it. It really looks like a syrup, and it's even less viscous than your hydrogel. I have one patient who came with from Thailand with a bump on the skin that resulted to a big blister and eventually a very infected eczema or a very bad bacterial infection in the skin. But with proper wound care and the honey, we were able to take out that. We initially did the Bridma, and I placed the honey. You can see after 1 day, there's very good granulation here compared to here. The holes in the side already been covered. And we did another Bridma, and the patient taught the patient how to apply the honey and the dressing. And as you can see, by 21 days, the wound is already close enough, and the patient is happy, and you don't have that crater form wound. Cadexamer iodine compared to povidone iodine or your betadine, are made of balls. These are spherical hydrophilic heads that absorbs the wound fluid and releases iodine in a timely manner at most 3 days. Compared to your povidone iodine or betadine, wherein when you put it on, it releases iodine immediately. So it's just a 1 day thing. I like cadexamer iodine powder because it has a dislocating and autolytic power to take out those difficult to treat wounds, but you cannot use it for prolonged periods of time. And there has not been any studies for children and lactating mothers. So this is what looks like. This is what we call golden powder. So we had the opportunity to use on this patient with necrotizing fasciitis that started with a pimple on the upper lip, which spread to the eye immediately, causing this necrotic tissue on the eye. And when this was referred to us for collaboration in East Avenue, we noted that these are quite difficult to take out. And with cadexamer iodine, you can see that after almost a week, you can already see very good beefy red granulation tissue and an exposed bone. And that's the time I told them we have to operate this on this patient to take out all the skunk. And we were able to see a very deep sinus tract or underneath the eye. And I told ophthalmology that we just have to really clean the wound. Eventually, you can do primary closure of the wound. And this is what it looked like post-dressing. And fortunately, this patient was able to heal with this wound. And it's just a cosmetic outcome on the left upper lip area that has to be addressed afterwards. Now, let's go to our non-adherent dressing. Very common is Tulgra dressing or Bactigra, Tuldra, whatever, Paratul. These are things. These are gauze impregnated with chlorhexidine or antibiotic. They need a secondary dressing, but they provide a traumatic removal. But you have to change it within 2 to 3 days, in my opinion, because they dry easily. And you don't put it like this, okay? Remember, they have to be exposed on the wound bed. And they do not have any role on the SPAR. So I corrected my residents on how to actually apply it in this case. But it has been very useful for those patients in financially challenged because Backtrack actually costs around 60 to 80 pesos, depending on where you buy it. And even though it's a slow acting wound dressing, as long as the patient follows up, you can see that after 6 months, we were able to close that very big wound on the patient. And this by patient is a Hansen's patient or a leprosy patient with a neuropathic ulcer. When you do your debridement, remember this you have to go deep. And this is an example of my resident sending me a pre and post debridement. Didn't see anything. I told him you have to go deep. If it's not red, it's dead. It's really have to go this very deep for you to have a very good source of new cells to fill up that gap. And remember, if it's bleeding, it's living. Then we also have this wonderful cellulose dressing created locally by our doctors in PGH and the nurse. And they actually collaborated with the OSC, I think, for creating Cocoa Patch. So it is made from cocoa cellulose. It is like coconut that you apply on the wound. It provides autolytic debridement and it's pain-free to remove. And because of the monolaurin, it has coverage for gram-positive and gram-negative bacteria. You can leave it on for a week. I don't think it can be left for 1 to 2 weeks. For me, 5 to 7 days was more than enough. We were able to use it on a patient with pyoderma gangrenosum, a neutrophilic disorder. Think of it as an increase in the immune system that causes wounds on the body of the patient. And before Cocoa Patch, the wound looked like this. And it really was painful for the patient to always change the dressing. But with Cocoa Patch, we were able to make it beefy red. And you can see here what it looks like, fresh and an old Cocoa Patch. And it's really not that painful to remove for the patient. And as you can see here, from this really, really murky looking wound from the left side, we had achieved a beefier red granulation for this patient. And the patient also experienced less pain during wound dressing. And we also use it on our babies with fragile skin. This patient had epidermolysis bullosa simplex, a problem with the integrity of the skin that causes blisters on slight trauma. And the good thing about it is that it's made of coconut, monolaurin. So it's safe for use for children. And you can see that after 8 weeks, we were able to treat the wound of this patient gently and slowly without even doing very aggressive surgical debridement. But the problem is with the feet, it just takes a while for the patient to heal. We have this more advanced dressing called lipidocolloid dressing. Same with bacterial, but it's not made of gauze. It's actually like they don't fall apart when you apply it, and when you cut it, it stays put on the wound. And I like it because you can leave it on for more than a week, and it comes with silver and no silver. And I like to use it on my surgical wounds, especially when I was starting to practice. I didn't actually have the nicest result with my surgeries, but eventually I learned how to do it with wound care. Eventually, I didn't have to use it when I was doing proper wound care. And you can see that the scar was just left with this hypertrophic one. And I like doing it in nail surgery as well, especially when I do partial onyectomy with chemical matrixectomy. I noticed that the wound healed better. There is also less dirt and slough, and there is less pain for the patient when we use this advanced wound care dressing. We also have hydrofiber. So these are things that you put it in the wound as fillers to actually fill up the gap, especially in those with undermining and tunneling wounds. And you can leave it on for up to 7 days, depending on the number of exudates. And it can have also silver. So this is what it looks like. And this is what I used for my patient here with a very big abscess that I took out from the right cheek. And there was a really big space left there. And after putting your hydrofiber, I placed a foam dressing and my transparent film dressing to keep it in place. You can use calcium alginate. It's made of seaweed. Basically, its purpose mostly is for hemostasis, especially if you have very bleeding wound. This is the best thing to put, and it also acts as a cavity filler for your undermining and tunneling wound. Foam dressings, I think we're all familiar with that. It may or may not come with antimicrobial. So it's basically to provide a structure or a template for the granulation of your wound as it absorbs the wound exudates. And it can be a prophylaxis for areas that are prone to pressure injuries. So we do get these kinds of wounds in PGH, and sadly, we have to answer the call. And while we wait for definite management, the role of dermatologists and us general practitioners is to actually provide proper wound care while we wait for definite management for this patient. So this is just a table of what I discussed regarding dressings. It's not by all the complete one, but I think this will actually help us to know when to use it, how to use it, and how long it can be left in your wound. Lastly, I just like to talk about dressings that bandages that will keep your wound in place. So you have this tubular net dressing that you actually comes in both different sizes. It's very porous, so it helps keep the things in place. So I like using it for difficult to treat areas like the head. So this patient had a tumor on the scalp from Langerhans cell histiocytosis type of cancer in kids we see. So it's easy. There's no bandage, and the baby feels more comfortable with it. You can also have this bioelastic conforming bandage that can also be used to wrap wounds without compression. It comes in latex and latex-free version, and I like it because it sticks to itself. And as you can see in when I mean with my discussion, I'm not talking about any medical adhesive, no micropore, transport, no tape, because those are actually causing problems with skin irritation and eventually skin tears that can lead to problems and chronic wound as well. But as you can see with with this kind of dressing, you can actually stick it to itself, wrap it on, and it's actually easy and light for the patient. I also like using wadding sheet to keep the dressings properly um, in place before I use my last bandage on it. And lastly, we have this self-adherent cohesive bandage that actually can be bought in Shopee. It's actually cheap. It's around 40. But when you use this one, it can actually provide stabilizing compression, especially for areas with edema. So this is an example of how I use it in my practice. So I stretch it, release a bit, and wrap it, stretch, release a bit, and then wrap it. So this is by far not a 20 to 30 millimeters mercury pressure, but it is enough to address the edema on venous stasis ulcer in patient. And in my practice, since I'm a nail surgeon and nail disorder specialist, I use it for my surgeries on the nail because it sticks to itself. It's like the fibrous bandage, and I do not use any tape. And as you can see, when you wrap it on, wrap it, fast forward, and you can also create a sandals to wrap it around the foot so that it's stable there. Now, I'm towards the end. I'm always already at the end of my lecture, so I just want to share a case that we handled in PGH. This is a very big 7-month non-healing ulcer on the right leg, and you know that there is a venous stasis component and lymph edema for this patient. So we did our wound stamp. We saw that it's very bright red fluorescence, but there's a tunneling wound here. And I told my residents that, it will be more difficult for us to know whether this is healthy or not. So what we decided is to take this out. And we are left with this wound here. And just because the wound became bigger doesn't mean it's not going to heal faster. We took out the one that's covering the dirt. And now that we're free to do debridement, we were able to clean the wound better. And as Dr. Tan a while ago mentioned, our wound should be healable by 30% smaller by week 4 so that it will heal by week 12. And as you can see, even after close to 1 month, compared to this one, we already have a very stable, at par, granulating wound bed to the wound edge. We're just controlling the maceration and eventually close. And with proper bandaging and compression, we were able to reduce the size of this feet of this leg of this patient to almost a normal size. And we were able to take out this verrucous thing, which is due to the edema. You can see the bandage works because there's this wrinkling of the skin here. So in summary, the dressing choice, really depends on your wound assessment and the principles of your wound care. And when the wound characteristic changes, you also have to change your dressing. And always use the wound debridement method you're more familiar with. You really have to try to know how much to take out. And remember, it's not just us dermatologists. Everyone can be a wound specialist. You just have to know which and what to use and the principles of advanced wound care. And these are my references. Thank you so much for your kind attention this afternoon.
Okay, thank you so much to Dr. Kuwa, Ma'am Stella. Maybe we could call in Dr. Atan, no? Maybe we have questions na po, no? One question from Ma'am Stella. Go ahead, ma'am.
My question is, has it ever happened to you, Dr. Val, that whatever dressing you gave, or what ointment or medicine that the wound did not heal? Because I hear those in patients with diabetes. The wound
Okay.
takes a long time. Sometimes they don't heal at all. So some are amputated.
Mhm. I think the problem with this type of wound is that most of the time people are just focusing on the hole. As I said, it's just the wound. So a lot of these patients would just think that they would rather spend on this dressing rather than address the diabetes. And diabetes actually affect our vascular the vessels. So if the vessels are compromised, no nutrients will actually go to the wound. And a lot of times as well with diabetic wound, aside from it is slow to heal, the dressings that they use are probably the incorrect ones. I cannot comment on what dressings would be right because again, depending on the type of wound, depending on the exudates, our dressings will adjust to that. And maybe people are either just applying dressings and not doing debridement. And we always have to do debridement to convert the wound from chronic to acute so that you can recruit healthy cells. So a lot of factors come into play, and even nutrition. A lot of our diabetes patients are sadly obese, and being obese is already a minute inflammatory environment for the wound. And not all obese are healthy because they also have sarcopenia, the loss of body muscle mass, and a loss of your lean body mass actually leads to immunosuppression and a 10 to 50% decrease in your wound healing. So ang daming factors that come into play. And all of this has to be taken into account when you see a wound.
Thank you very much for your answer. There's a question here from Maria Carmela Uy. Where can the items be purchased? So the stretch net and other specialized wound care items locally.
Okay. Okay, the problem with this one is that our example for Mercury or Watson's, these drugstores will not stock on these dressings if they are not being ordered by doctors. So a lot of times, this advanced wound care dressing will be found in hospitals. And even in Butuan, where I practice, this is a province, but we do have this one because our hospitals understand the importance of using advanced wound care appliances. We are able to order it. And I think in Philippine General Hospital, we also have them. It's just that it's difficult to take them in because of the bidding processes compared to private hospitals. But the distributors are here. We have advanced dressings here in the Philippines. Just a matter of it's a matter of our hospitals and clinic tapping them, making them available for purchase in our clinic. And it's not expensive. It really just depends how much you want to make patong on them. If it's charity, sobrang mura niya talaga. It's not expensive to use this advanced wound care dressing. It's a common misconception.
Thank you for your answer, Val.
And
Back
I
to you.
think, Doctor, to add to that one, it actually it even if they're not as cheap as gauze, I would say. Of course,
Mhm.
gauze and plain NSS are very cheap, but when you're using the appropriate dressing and the wound heals well versus you proceed to an amputation or um of course you would entail more expense for those things, and if it's very debilitating and very poor quality of life for the patient. So if you can weigh those things, I think if you can properly kung makapaglaan ng budget for that, both the hospital, the
Mhm.
clinician, and the patient, there is a lot that can be saved
I
for
think
you.
also to add to that is that with these dressings kasi, you can leave it on for longer periods of time compared to 3 times or twice a day change of dressing. You also have to think about the caretaker because there's caretaker fatigue. Mismo ako, ang doctor na mapapagod ako if I keep on seeing the patient every day. Kawawa naman sila. Transpo pa lang papuntang hospital, the dressing pa. So you have to explain to the and when we do explain this to the patient in our charity, they understand. Once a week na lang pala ako babalik, so mas convenient. So it's not about the expense din eh. Parang yung convenience nila na parang hindi na sila magpapalit ng dressing sa bahay, kami nang gagawa, and once a day, once pupunta lang pupunta, and they see progress. When they really see the progress, these patients will really be willing to invest compared to just putting saline gauze and micropore tape. Ang laki ng difference talaga.
Okay, I have no more questions, Dr. Estela. And in the days of the time also, we'd like to thank our speakers, Dr. Nicole Tan and Dr. Val Kua from the Department of Dermatology, the UP Philippine General Hospital, for sharing their time and their insights today for our webinar this week. So at this point, we'll be flashing on the screen the evaluation poll. So we can have that on the screen. Okay, it's 5 statements, 4-point Likert scale. So we'll not be closing this until the end of the webinar, and we request everyone to put in their answers here in this panel discussion poll. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, panelists spoke clearly and audibly. Number 4, the panelists used appropriate language and technical medical jargons adequately explained. And 5, finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. Okay, for next week, Dr. Estela, what do we have, ma'am?
For next week, our speaker is Dr. Lana Tan, and she will talk on egg preservation. Ano kasi siya, she's an REI, reproductive endocrine infertility specialist.
Oh, okay, okay. Thank you so much. So in the meantime po, you can still watch us on the playback at the TVUP YouTube channel and at TVUP Signal TV channel 101. Maybe I'll just take this opportunity to greet those who have joined us today. So there are those who are watching us locally, domestically, from the Mariano Marcos Memorial Hospital and Medical Center in Batac City, Ilocos Norte, from Camp Navarro General Hospital in Zamboanga City, Zamboanga del Sur, from Bataan General Hospital and Medical Center. Maraming salamat po. St. Mary's Educational Institute in Lemery, Batangas, and Mayor Hilarion A. Ramiro Sr. Medical Center in Ozamis Occidental. Also those from First Gen Corporation from the province of Bataan, province of Quezon, province of Davao, Cebu City, La Consolacion University, Philippines in Malolo City, Bulacan. Maraming salamat po. From the City Health Office of Antipolo, thank you so much. And then from the UP Philippine General Hospital, thank you. Air Force City Hospital, also maraming salamat po. And UST Hospital. And then internationally, we are being viewed. So another shout out from the Lee & Co law firm po in Seoul, South Korea. Also from Juno, Sutra, and Sarantis. Maraming salamat po. From Chonin Hospital in Taipei City in Taiwan. Thank you so much. Ryan Hall. Shanex Incorporated, Bridgewater, Canada. Université Saad Daleb, Oulad Yaik in Algeria, and University of Hail in Hail Kingdom of Saudi Arabia. So maraming salamat po sa inyong lahat. And then we also, before we conclude our program, we also reminded you that all health updates webinars are archived for viewing at the TVUP YouTube channel. So just go to www.youtube.com/TVUPPH. If you go to the live tab, it will be 256 episodes na po ang nandoon. After today, it will be 257. We also understand everyone very busy, so we have selected some presentations po, no, that we feature in snippets. So if you just go to the same YouTube channel, if you go to the shorts tab naman po, you'll be able to watch them at your convenience. Yung tinatawag po naming health updates shorts with the playlist at the TVUP YouTube channel. So this formally closes our program and our webinar for this week. Makita-kita po tayo again next Friday from 12 noon to 1 p.m. It's a day.
Together, we can stop preventable deaths.
So keep safe, keep healthy. See you online.